What's going on? DeLaney here. And if you're a regular listener to ERCast, you know that each month we cover a handful of papers on lit matters. And we try to get up-to-date, kind of cutting-edge papers on this show. Occasionally a paper will come out where we just can't wait for the next month's episode. The findings, the results are too practice-changing to wait for Lit Matters to air the next month. We've got a paper today that checks all the boxes. This is hot off the presses, out today. The pragmatic trial examining oxygenation prior to intubation. The Pre-Oxy trial by Gibbs et al. Just out today in the New England Journal of Medicine. And to walk us through this enormous change in the landscape, we're joined by a longtime friend and colleague, Dr. Stephanie DeMasi. Stephanie, welcome to the show.
DeLaney, thank you so much for having me. It's such an honor to be here.
So, Stephanie, we've worked together in the past. Our career paths have taken different directions, and this paper is right out of your world now. So tell us all, who are you and why are you pumped about this paper in particular?
I am faculty at Vanderbilt, and I'm also the site PI for this clinical trial network that runs these trials investigating questions in critically ill adults in the emergency department and ICU. And I'm also part of the coordinating center. So I jumped into this role to get involved in research that is pragmatic, that brings science to the bedside for our patients.
And I love the idea that it's a pragmatic study, that this is something where we can read this, we can talk about this, and then, not to spoil the ending, we can take this to our next shift.
Yeah, absolutely. And these types of trials are directly applicable to what we do every single day in the emergency department to a broad patient population.
All right, and so this Pre-Oxy trial is looking at preoxygenation, which I always think of as the least sexy part of the airway management process, but it's important. And so just kind of set the stage. How important is preoxygenation when we're looking at a sick adult who's going to need to be tubed?
For the 5 million critically ill adults that undergo emergency intubation in the ED and ICU each year, intubation is a life-saving but high-risk procedure. Up to 40% experience a complication, with one of the most common complications being hypoxemia, which occurs in about 25% of patients. We care about hypoxemia because it's closely linked to cardiac arrest and death. That's why we care about preventing hypoxemia during intubation. Our goal is to prevent a death.
Stephanie, how bad is hypoxemia? I'm thinking of airways I've done where, they drop their sats a little bit and the nurse is like, well, I didn't really see that low sat. I mean, it's something that seems very transient, but it has very real ramifications for the patient. How bad is it?
If a patient experiences hypoxemia during intubation, there's 3 to 4 times greater odds of cardiac arrest and death. And 1 in 50 intubations experience hypoxemia. So it's going to happen at some point in your career, whether you expect it or anticipate it or not. And those odds are high.
3 to 4 times is wild. And I guess it's based a little bit on how sick are you to start with, but still 4 times your risk. That's a shocking number. And I don't want to be flippant when it comes to preoxygenation. I think that it's obviously a crucial part of getting a patient ready to be tubed. I'll be honest, what I typically do is put a non-rebreather on the patient, crank up the oxygen. I feel like I'm doing a good job. How effective is that?
And that's what we were taught, right? And that's what's been status quo. Oxygen masks are currently the most commonly used form of preoxygenation, and 80% of patients worldwide are receiving preoxygenation with an oxygen mask. It can give anywhere from 50 to 100% FiO2. And that's assuming if the wall O2 is cranked all the way up, like, usually 15 liters, or we say flush rate. And it also assumes that you've got a perfect seal around the mouth, which you and I know is rare. That being said, there are positives about a non-rebreather. It's quick to set up and it's universally used. In fact, if we're saying in the room in the ED that we're about to intubate a patient, somebody in the room is grabbing an oxygen mask with a non-rebreather. Whether it's the tech, myself, one of the nurses, it's just become such second nature in the status quo. That's what's really interesting about this trial, because it's challenging what's been the status quo. The negatives, however, are that it provides no positive pressure, right? No ventilation, and this imperfect seal may only be resulting in 50% of FiO2 provided to your patients. So maybe that's not enough.
Yeah, and you said that we were taught this, and I was taught this. I've taught plenty of people this, and I've always felt like while it's not perfect, it seems to be what the guidelines would push us towards. Stephanie, I think that this paper inevitably will change guidelines, but today, right now, the guidelines are the same. What do the guidelines recommend we do to pre-oxygenate patients?
Yeah, so across the board in both the ED world and the critical care world, they state that essentially we can pre-oxygenate with either a mask or a non-invasive device. Either are acceptable, hence the equipoise that led to this trial.
Yeah, you ask me what I want to do, and it's either I can put a mask on you or I can find the respiratory therapist outside smoking, make them put out their cigarette and come in. I'm going to choose oxygen mask. And there's this equipoise. It's a jump ball, right? If I'm given two options, I feel like both must be decent, but you pointed out very clearly that oxygen masks aren't ideal. So that sets this up perfectly. The Pre-Oxy trial out today, New England Journal of Medicine. Walk me through the setup for this trial.
So this was a multi-center trial, again, through this large, pragmatic critical care research group network, the PCCRG. This trial enrolled at 24 centers across the United States, 7 EDs, 17 ICUs. It was a parallel group, unblinded, pragmatic trial that enrolled critically ill adults undergoing emergency intubation, and patients were randomized to receive either non-invasive or oxygen mask for pre-oxygenation. There was a broad inclusion criteria. Patients were enrolled if they presented to a participating unit, so one of these 24 sites. They were going to be intubated with a laryngoscope, and the operator was a clinician that routinely intubates in these locations, so all comers. Importantly, patients were excluded if they were already receiving positive pressure by any device. So if they were being brought in by pre-hospital providers, already being bagged, already on the vent, have an LMA in place, if they were apneic or hypopneic, those are important exclusion criteria. And in addition to if the urgency of the intubation procedure precluded enrollment in the trial, or the operator determined that either a mask or a non-invasive device was required or contraindicated. And these exclusion criteria are important in that these aren't our COPDers being brought in on BiPAP, right? These aren't our apneic patients being bagged, but it's everyone else. It's our undifferentiated encephalopathic patients, it's our trauma patients, it's anyone else that's being brought in that needs an airway.
Stephanie, I love this big, broad inclusion criteria. Basically, I'm looking at you, I think you need an airway, and now I'm getting randomized to either the oxygen mask group or the non-invasive group. We're going to talk about the specifics of what you're supposed to do in each group, but walk me through the steps involved once we've decided this patient needs to be tubed.
I'm glad you brought this up. I think it's helpful to define the steps. In general, our first step when we're preparing to intubate is the pre-oxygenation period. And this is what this trial is focused on, that period prior to medications being pushed while the room's kind of bustling, things are getting ready. This is what we're focusing on for this pre-oxygenation period. Step number 2 is induction. This marks the end of the pre-oxygenation period, and this is when medications are pushed through the IV. Usually it's a sedative followed by a neuromuscular blockade medication. And then step number 3 is the start of laryngoscopy, or when the blade enters the mouth. So again, we're focusing on step number 1. So back to the oxygen mask group. If your patient was randomized to this group, patients could either be pre-oxygenated with a non-rebreather device, so the face mask with a non-rebreather bag, or they could use a bag valve mask without the bagging. So place the seal over the patient's mouth and provide 100% FiO2 without the actual ventilating breaths by bagging. The trial also provided best practice recommendations that instructed operators to administer this oxygen through the mask, whether that's the BVM or the mask with a non-rebreather, from pre-oxygenation all the way until the start of laryngoscopy. So like we defined step 1 to step 3, and to administer the highest flow rate of oxygen available. So ideally flush rate up to 15 liters per minute.
All right. So in the non-invasive group, what did they use and what were the settings?
Sites were instructed to use the vent that was going to be used post-intubation. But they were allowed to use a dedicated BiPAP machine should that have been more feasible for any given reason. Just like the best practice recommendation in the mask group, there were best practice recommendations for the non-invasive group, meaning that they advised the setup of an FiO2 of 100% on the non-invasive device, either via the ventilator or, again, the BiPAP. an expiratory pressure of at least 5 centimeters of water pressure, and an inspiratory pressure of at least 10, and a respiratory rate of 10.
Stephanie, you talked about the steps, and step 1 is preoxygenation, and you said that no matter what group you're in, you're going to get preoxygenated until the laryngoscope goes in the mouth. Was there a time period where they said, hey, try it for this long?
So the trial protocol recommended at least 3 minutes of preoxygenation in both groups if it was logistically feasible. And this 3 minutes of preoxygenation comes from pretty robust data that says that at least 3 minutes is required for sufficient preoxygenation.
Could clinicians choose to do other stuff? Could you bag the patient? Could you leave a nasal cannula on once you started the procedure after they've been paralyzed?
Yeah, so owing to the pragmatic nature of this trial, both groups were allowed to provide supplemental O2 by either a nasal cannula or high-flow nasal cannula during preoxygenation and during laryngoscopy. In addition, both trial groups, clinicians were permitted to bag the patient between induction and laryngoscopy, again, should they decide to. This, in the non-invasive group, translated often to the device just being left in place all the way until the time of laryngoscopy. So it wasn't that they were doing two different things if they were in the non-invasive group, but they had the option to do that. It was not required.
All right, Stephanie, break down the primary outcome and the secondary outcomes. Kind of what in general were folks looking for when they designed this trial?
So the primary outcome of this trial was hypoxemia, which was defined as an oxygen saturation of less than 85% between induction and 2 minutes after intubation.
That's a low sat. Even if I'm seeing 85, I'm like, yeah, you really did actually T-sat. So primary outcome, sats less than 85%.
Yep.
What were the main secondary outcomes you guys looked for?
The secondary outcome was the lowest oxygen saturation between induction and 2 minutes after intubation. And we also looked at things like cardiac arrest between induction and 2 minutes after intubation, which we have thought of as a potential downstream complication of hypoxemia.
All right. So results. What did they find in this pragmatic study looking at non-invasive ventilation versus non-rebreather cranked up?
This trial enrolled 1,301 patients that were randomized and included in the intention to treat analysis. There were 616 patients enrolled in the non-invasive group, and there were 648 patients in the oxygen mask group.
One thing that jumped out when I was looking at this paper is that no matter what group you were randomized to, it looked like folks actually were pretty successful in terms of pre-oxygenating the patients.
Yes, so the vast majority of patients were able to complete that 3 minutes of pre-oxygenation and achieve saturations of at least 95% in both groups. Much like previous PCCRG trials, there was excellent separation between groups and adherence to group assignment, meaning if you were randomized to non-invasive, you got non-invasive. If you were randomized to face mask, you got face mask. But even after the pre-oxygenation step, so step 1, you already see a difference in the groups favoring non-invasive, not to completely spoil the results.
Okay, so this is interesting, though. Both groups were pre-oxygenated pretty successfully. So you could look at it and say, the oxygen mask works, the non-invasive ventilation works. There may be some subtle differences, but it works. You paralyze the patient, I'll put the blade in their mouth. What did they find in terms of the rates of hypoxemia?
The rate of hypoxemia between induction and 2 minutes after intubation, which again was the primary outcome of this trial, was 18.5% in patients in the oxygen mask group and only 9.1% in the non-invasive group. That's an absolute risk difference of 9.4%. That was statistically significant with a p-value of less than 0.001.
So I'm looking at these two patients. One's on BiPAP, one's got a non-rebreather. I start the procedure, both SATs are above 95%, yet you're telling me if they were getting the oxygen mask, the chance that they desat is 18% versus only 9% if they got the non-invasive pre-oxygenation.
Right. And remember, this is all comers. This is patients that are being intubated for acute hypoxemic respiratory failure and patients being intubated for all other reasons that we intubate patients in the ER. So maybe patients that we were worried would become hypoxemic, and then patients we perhaps didn't think we had a significant chance, like you alluded to earlier.
That's wild. So that's the primary outcome. What about secondary outcome? You talked about the median lowest oxygen sat. How did the groups look?
So their secondary outcome of lowest O2 sat was 99% in the non-invasive group and 97% in the oxygen mask group, a difference of 2%, a result that was also statistically significant.
That's interesting. We know that folks were more likely to desat in the oxygen mask group. But if you looked at just the median numbers, you could look at all of these patients and say, generally, their sats are actually pretty good if you're looking just at that median lowest O2 sat. But it's those cases, like you said earlier, that come along out of nowhere are twice as likely to desat significantly if they were in the oxygen mask group.
Yeah, absolutely. And what's so interesting is that results were equally as strong when we evaluated hypoxemia with different thresholds. 85%, 80%, 70%, no matter which way you did the binary outcome, it favored non-invasive.
That's interesting. So what about the other stuff? Rates of cardiac arrest, risk of aspiration. That's one of my big concerns is an altered patient. I pop BiPAP on the patient. Did you see any signal of harm in the group that got the non-invasive ventilation?
Yeah, so this trial, it appeared that by preventing hypoxemia, non-invasive also prevented cardiac arrest, where one patient in the non-invasive group experienced a cardiac arrest within that 2-minute period of post-intubation, whereas there were 7 patients in the oxygen mask group that experienced a cardiac arrest. This difference was significant. So if this is true, using non-invasive during intubation could prevent thousands of cardiac arrests each year and dramatically improve the safety of our patients. Further, people have avoided non-invasive in part because there is this theoretical concern that it would lead to an increased risk of aspiration. And despite enrolling a very sick and high-risk patient population in this trial, there was no evidence that non-invasive caused aspiration, which occurred in only 6 patients in the non-invasive group and 9 patients in the oxygen mask group.
That's a big takeaway. So sick people do sometimes aspirate, but they're not aspirating more because they're on positive pressure ventilation.
Exactly.
Stephanie, this was a big study, multiple centers, and interestingly, it was ED patients and ICU patients. When you look at the results, did where you get intubated make a difference?
So non-invasive was favored both in the emergency department and the ICU. The overall rate of hypoxemia was lower in the ED when we compare it to the patients in the ICU, but the benefit was similar. And we also did formal interaction testing that did not suggest that the ED versus the ICU location modified the effectiveness of non-invasive for pre-oxygenation.
All right, Stephanie, I want you to take off your scientist hat briefly and put on your hype woman hat. What is your take on this paper?
We really do feel this trial is practice changing. It showed a larger benefit for non-invasive than we anticipated. And importantly, it dispelled these hypothetical concerns regarding risk of aspiration. This trial enrolled a broad, generalizable patient population, which is particularly applicable to me and my clinical hat in the emergency department. And I am excited to use this to improve the care of my patients.
Here's the question that I know is hard to give an official answer, but I don't care. I'm going to make it personal. I come to Nashville. I go down to Broadway. I get one too many Long Island iced teas at Kid Rock's Honky Tonk Badonkadonk Club. And I come in and I'm altered. I'm choking on some vomit. You correctly identify that I'm a moron who needs to be intubated. How are you going to pre-oxygenate me?
Okay, so this trial, while we had 60% patients that had an acute encephalopathy at the time of intubation, if you were actively vomiting, I would not pre-oxygenate with you with a non-invasive, right? That was one of the exclusion criteria, which I'll mention. Less than 2% of patients were excluded for, so a very small number of patients. So let's say you went out to Broadway, but you didn't get sick yet. So you were just altered, but you were not apneic and you were not vomiting, then I would be pre-oxygenating you with a non-invasive device. Ideally, with the ventilator being wheeled into the room, used as a BiPAP machine, so setting it up like a BiPAP, such that we're using a single ventilator.
Okay, so you're convinced based on this paper that we should change our practice for pre-oxygenation for the vast majority of sick patients who we're going to intubate. This is ready for prime time.
Yeah, absolutely. I think it's ready for prime time, right? This was a multi-center trial across the entire United States, broad patient population with excellent design characteristics. I have no bias in that. Yes, absolutely think it's ready for prime time.
Are there any issues or questions that still remain? You're looking at this study. This is a big study. This is a practice-changing study. What's the little voice in your head saying, well, actually, we need to be a little bit careful?
I think the implementation aspect of this trial is going to be a challenge or require a little bit more thought and coordination, particularly at some sites. So, as I alluded to earlier, my ideal scenario and what we would do at my shop is use the ventilator using BiPAP settings. This may require some additional training with respiratory therapists or clinical staff to understand how you set up the ventilator into the BiPAP mode. But generally speaking, it's easy. It's switching the mode to non-invasive, and some require an adapter to fit the face mask onto the ventilator, but that's it. And then the same machine can be used post-intubation.
So I have a patient, I'm going to tube them. I tell respiratory therapy, bring the vent in, put it on BiPAP setting, and then I'm going to preoxygenate for 2 to 3 minutes, then get them tubed, and I'm going to cut the chance that they desat by half.
That's right, for 3 minutes.
That's easy. That is easy. Stephanie, one concern I had after reading this paper was it looked like 20% of the patients got screened but didn't get enrolled because they said, hey, the airway is too urgent. I know that scenario. You and I have been in that scenario. How does that mix into the results of this study?
Yeah, that's a good question, and I'm glad that you brought it up. This is a common reason for exclusion in emergency airway trials. So not just this trial, but across the board for airway trials. And the reason for that is, like you alluded to, we know what this is like when we have a patient in extremis. It's often too urgent to complete trial procedures. And again, this is a pragmatic trial, so we minimally interrupt the day-to-day clinical practice, but it still requires getting an envelope, identifying someone to collect outcomes. It takes effort. So it's not uncommon, and it's somewhat to be expected that not every single patient is getting enrolled. Furthermore, I can't help but think that these patients that were too urgent to enroll because of their extremis, that they wouldn't have benefited from non-invasive.
That's really interesting. So it may just be the machinations of what it takes to put somebody in a study as opposed to the brief time period it takes to get the vent in, get it in BiPAP setting, and then create a safer situation for the patient.
Exactly.
I love it. Stephanie, this is a major paper. Close us out with key takeaways, things to think about on the way to our next shift when it comes to pre-oxygenation.
I'm telling you, this trial is going to change my practice. Going forward, I will be using non-invasive for pre-oxygenation, ideally for 3 minutes prior to intubation. From this trial, my understanding now is that the risk of aspiration with non-invasive is small, if any, and it's outweighed by the risk of hypoxemia.
This is fantastic. It is rare to get a paper where I really feel like I'm going to do this on my next shift. I think we're there with this. Dr. Stephanie DeMasi, this has been a treat. Thanks for the breaking news. We'll talk to you soon.
Thanks for having me. It was an honor.